academic year. I'm going to do some housekeeping first and a couple of announcements, but I did want to share with you that as of, if I can figure out, you see, we have 66 people remotely attending. Thank you all that are here remotely. And in the room, we have 40 to 50 folks. So this is terrific. Thank you very much. It's good to be back in person. Just a couple of housekeeping things as we experienced last week when we're doing the hybrid. If you have a comment or a question so that the folks remotely can hear and engage with us, make sure you get up and use the mic, or we have a traveling mic. Great. Okay. So you guys at home, we'll make sure at home. Yeah. Wherever you are, we'll make sure you can hear. As I promised last week as well, I did a little survey about how long grand rounds should be, and it's not all in yet, but in less than 12 hours, I have 68 responses. So far, it's 56 to 12 for 60 versus 90 minutes. So unless the second half, I sent it out to 133 faculty. So unless the second half of the group goes completely 90. What was that? Oh, the mail-in ballots have not been counted. Today's 90 minutes, but it looks like we'll probably shift back to 60 minutes, but I'll let you know. Okay, and before I have the privilege of introducing our guest speaker, the Maryland Psychiatric Society asked us to make an announcement to our residents, fellows, and all our trainees. And so Dr. Aaron Reich is going to make that announcement for us. Mark.
So I just have a few things to point out for our trainees. So the Maryland Psychiatric Society is once again having a poster and paper competition for residents and fellows. We've had past awardees from the program, and there is cash prizes. So I'm encouraging people to submit their posters and papers for that. We also have the APA sponsors a number of honorary competitive fellowships that are now open for application. And so residents and fellows that are interested in that should take a look at that. We'll be sending out a link for people to look at for those fellowships. This Saturday, there's also a psychopharm update that's being sponsored by the MPS, and residents and fellows can go for free. If you want to do that, it's at Martin's West. Actually tonight at 7:30, the early career psychiatrists, and it's also open to residents and fellows, are having someone come talk about physician contracts if people are interested in that topic. That's tonight. And in February, there's going to be a trivia night at Home Slice again. And also in February, we're hoping to have in-person advocacy day down at the Maryland General Assembly to advocate for psychiatric issues. And I think that's it. So thank you.
Thank you, Mark. Okay, so it is my privilege. I'm very excited and honor to introduce our guest speakers today. I'm going to introduce our speaker, and we have a wide range from his team, and Eric will introduce his team as they speak. So Dr. Aaron Weintraub, I think most of us, if not all of us, know Eric. He's a graduate of our programs here, and joined the faculty right out of residency, along with a number of us. I was just a year or two ahead of you. 1 year? Yeah, right. So Eric is an amazing, don't use the mic on that one, Eric. So Eric, Dr. Weintraub is an amazing individual. He is the director of our Division of Addiction Research and Treatment for the past 20 years, and a director of our Psychiatric Emergency Services for the past 11 years. He's an expert in the treatment of individuals with addictive disorders and has a local, regional, and national reputation for his work in the establishment and implementation of novel clinical initiatives to expand medication-based treatment for addiction, particularly to the underserved population in Maryland. What Eric and his team have done over the past 20 years is really amazing. When I think of what our addiction line was when we first came on board and what it is now, it's a totally advanced and developed array of education, clinical, and research initiatives. He has done an amazing job moving from a basic office-based methadone treatment program to the use of telemedicine way before COVID, I might add, to reach rural Maryland and those without access. He has partnered with local, county, and state partners to create access to medication-assisted treatment across Maryland via mobile telemedicine using his vans, the purple van. Although you have a new van, I don't think, is it purple still? Okay, great. We'll get to see a picture of it. He's the PI of MAX, which is the Maryland Addiction Consultation Service, providing guidance to clinicians, any clinician throughout the state, working with individuals with addictive disorders, particularly opiate use disorders. Washington got wind of this, Washington, D.C., and they wanted one. And so now we have a DC MAX, DCAX, DDAX, whatever you call it. He has trained emergency medicine docs, general practitioners, and acute care providers in the initiation of bupropion. And when I say he, I do refer to his whole team, which you will have the privilege of meeting today. If that wasn't enough, Eric has established telemedicine reach out programs to individuals in county jails with opiate use disorders, providing Suboxone treatment while incarcerated, which reduces death rates of inmates upon release from jail because they leave after not using for a while, immediately pick up again and overdose. His division operates not one, but two fellowships for residents, or for fellows, and has embarked on some amazing research. But I will let Eric and his team tell the rest of that story. So please join me in welcoming Dr. Eric Weintraub as he presents Shot Through the Dart, an overview of the Division of Addiction Research and Treatment's clinical, educational, and research initiatives.
Thank you, Jill. Thanks for that kind introduction. One of the reasons we wanted to have this today was to have everybody else introduced that's really responsible for this work. I get a lot of the credit. My name's mentioned a lot, but we have an incredible multidisciplinary team that really has operationalized, implemented, and come up with novel ideas to help individuals with substance use disorders. Unfortunately, I'm not going to be able to give them the same generous introduction because we just don't have time. So the introductions will be brief. We try to cover a few of our programs. Unfortunately, we didn't have time for everything. So people like Joy Chang, who's an important part of our division, Avi, Rompashot are not going to be presenting, but they're critical components. Don Thompson, who runs our sports psychiatry programs and works on the CL service, are not going to be part of this presentation. So anyway, I'm going to get started. And I think you can tell by the name of this talk that was not created by me. So I want to thank Mimi and Sarah and whoever else was involved in coming up with that name. So I'm going to start off by talking a little bit about our telemedicine programs. This is going to kind of operate like our division, like to call it controlled chaos, where we have not rehearsed this, and we're going to run through 6 presentations, and we'll try to do it in a timely manner. Other than Dr. Catacuzzi, who has to leave, we're just going to hold questions until the end of the discussion. So see if I can get this going. So this is what we're going to be talking about today. I'm going to talk about the telemedicine programs. Sarah, anyway, we'll let everybody introduce their studies as they get there. So like, as Jill said, we got involved in the telemedicine space back around 2015. It was really Dr. Welsh, who's been on the ground with me and helped establish all these programs. Starting at that time, I can't really tell the whole story, so I'm going to focus just a little bit on why we got involved in one of our programs that we have operating now that's gotten some recognition. Bottom line is, just to go over this, everybody knows we're in the midst of an opioid epidemic. Since 1999, there's been just dramatic increases in overdose deaths. And you can look at the numbers there. It just shows you how serious it is. And I think this slide sort of summarizes it, that somebody's dying, in every 10 minutes from an opioid overdose or an overdose deaths, and 70 to 80% are related to opioids. What's happened since the epidemic started is you can see the dark blue areas are where the epicenter of the addiction of the overdose epidemic is, and it's not directly correlated with urban areas. So there's been a shift in where this has occurred. Opioid use disorder and overdose deaths were predominantly an urban phenomenon issue until the overprescribing of opioid medications began in the 1990s. And I'll talk about this in a minute, but basically the infrastructure for the treatment of opioid use disorder was centered in urban areas. Most methadone programs, most providers were there. So we were ill prepared to take care of what was going on in suburban and rural areas when things exploded there. So I thought, yeah. So basically the bottom line is that there is really good evidence-based treatment for opioid use disorder, and we can get better, and we're looking for better medications and better treatments. But we do have 3 medications that are FDA approved that work when people take them and are prescribed them, and they increase retention and treatment, decrease illicit opioid use, which are the primary outcome measures for the treatment of opioid use disorder with medications. But they also decrease rates of overdoses, improve social functioning, decreases the transmissions of infectious diseases, and decreases criminal activity. And all of us that have worked with individuals with opioid use disorder have seen this transition in many patients who are in and out of jail, not doing well. When they get stabilized in treatment, their lives turn around dramatically. Clearly we have a long way to go to get better medication so we can keep more people in treatment for longer periods of time, but we do have medicines that work. Unfortunately, only a small percentage of Americans with opioid use disorder get it. And there's a variety of reasons for it. We don't really have time to discuss all the issues, but they range from just lack of access because there are no methadone programs in a particular area or no buprenorphine prescribers, to stigma related to the use of medications for opioid use disorder because they are opiates, and there's the whole stigma of you're addicted to another medication, another opioid if you take buprenorphine or methadone. So there's stigma that pervades not only providers, but the community and even our patient population. Next slide. So as I showed you, rural overdose rates have exploded over the last 15 years. Again, predominantly an urban problem. We didn't talk about this in the 80s and 90s about taking care of patients in rural America, rural Maryland that had opioid use disorder. It was Baltimore City. That's kind of where Chris and I and the people that have been here long enough, like Don, kind of cut our teeth in taking care of people in downtown Baltimore that had opioid use problems. And you can see there was a recent study that came out in 2021 that looked to see where treatment for opioid use disorder or medications for opioid use disorder were available. And as you can see, many counties across the country do not offer these services. Methadone programs it's rare to find methadone programs in remote rural areas, even in rural areas. I worked in Oakland, Maryland, which is in Garrett County, which is not really that far from Allegheny County, where the closest methadone program is. It's a 30 to 40-minute drive, but it was almost impossible for the patients that lived in Garrett County to get methadone in Allegheny County, just because they had to be there every day because of the regulations. Transportation was an issue, weather was an issue. So there's just a lack of availability of treatment, as you can see from this slide. I'll thank Kelly Coble for this slide, but this is a slide that shows that there's a healthcare professional shortage throughout parts of Maryland. And a lot of our work has actually been done on the Eastern Shore. And you can see the dark blue area, while not specifically related to substance use treatment just shows that there's a real dearth of providers for any kind of mental health treatment on the Eastern Shore. So for the residents that are looking for work, that is a place to go that people, they really need individuals to provide this kind of treatment. So Chris and I, like I said, we've been doing this since about 2015, and our model, we knew how to take care of people with opioid use disorder. We're not technologically savvy, but we kind of figured out the telemedicine, video conferencing, and we developed relationships with different rural treatment centers. I'm going to skip the DEA part, but all the patients receiving buprenorphine are enrolled in a program. They have a counselor. We're able to get urine toxicology screens on them. We're not seeing patients in their homes. And this is a model that, works for us in Maryland, because rural in Maryland is very different than rural in Alaska or New Mexico, because there's a pharmacy and a treatment program within 30 to 45 minutes of anybody in the state of Maryland. We've developed standard operating procedures over time. And we found that having a program coordinator on the other end has really been helpful in keeping us organized about who needs prescriptions and, just following up in general. So these are our current programs. We've had other programs, but the basic ones are at the Wells House. That's our original program. We're still running that. It's still a pretty big program, a major training site for our fellows. I'm going to talk a little bit about our mobile collaborative in a minute, and Mimi's going to talk about our justice telemedicine program, which is in the jails. And the Caroline County Health Department is one of our original sites, and the mobile unit was an offshoot of that. Just real quickly, we've written a couple papers about how we were doing. We wanted to kind of see if our patients were doing as well as patients in face-to-face treatment. And this is not a randomized prospective study, but when we did a chart review, it seemed like the outcomes were pretty similar, where we saw, most people staying in treatment, and we saw a decrease in opioid use among our patients. So what we found in Caroline County was, even having a site in Denton, which is the township of Caroline County, that there were a lot of individuals that couldn't make it to Denton. It's a very small county. I think geographically one of the smallest in Maryland. When we got there, there was not one buprenorphine waivered provider in the whole county. But they had a very kind of innovative addiction lead named Joe Jones. And we heard about this HRSA grant, and we came up with an idea of, well, let's try to get a mobile unit. And that's kind of a lot of times we had some ideas, and we figured we'd figure it out once we got the funding. Our initial thought was that we were going to chase down people that had overdosed in the community, find where the hot spots were, and try to treat them. And it turned out that wasn't the best way to go. And we kind of evolved as time went on. So what we learned was, and I'm going to go to the next slide, was the best way we could serve the community with this program was, so we got funding to provide staff and do some research. It was actually we had to go to the state of Maryland because we didn't put enough money in for a good vehicle, and BHA actually gave us funding for a van. But we found was that running small clinics on a weekly basis in different small towns and just leaving the door open was the best way to engage the community. So we advertised, we partnered with churches, we parked the van in the same spot, like for a 4-hour clinic. And each of these are different areas where we had clinics. It's shifted a little bit, so that slide's a little bit old. And what we did was we had I'm going to go back. We had a low threshold model where we would do walk-ins. We would keep an open door. We weren't kicking people out of treatment. We were trying to provide as much other ancillary care as we could, because there's no psychiatrist there. So we do as much mental health work as we can. When we brought some of our medical providers or physicians on, like Sarah, there was more medical work being done, or Aaron Greenblatt, who's family medicine trained. So this is kind of how we're operating now, where we do different clinics in different small towns, and just, we'll have appointments. People get urine toxicology screens, are treated just like a regular clinic, other than I'm in Baltimore while the rest of the treatment team is on the van taking care of the patients. We wrote an article that got published in JAMA Network Open. And basically the numbers were pretty similar to what you saw in the Wells House paper. We've seen, over 300 patients. And again, this is a year old. So I didn't look at the data today. But we probably have close to 125 to 150 active patients. Our retention rates at 3 months were approximately 60%, which is similar to what's in the literature for face-to-face treatment. And we saw there was significant reduction in travel time and distance and opioid use, which made it convenient for our patients to get to the van. I was reading a recent perspective that was written by Rahul Gupta, who was the director of the ONDCP under Biden. And I really didn't know this ahead of time, but I was looking through it and I was looking at one of the references. There's only 5 and my name popped up from the previous paper and I would like scramble back to the paper and he actually wrote a whole column in this perspective on our treatment, on our van treatment program, which we were very excited about it, that he never let us know that he was going to write this, but he did signal out our program. Just real quickly, as far as grant funding, the initial grant that we got was a HRSA grant, 3 years. It was about 900,000. It was, I don't know where the 18,000 came from, but it was 300,000 a year for 3 years. And we recently, or I shouldn't say we, it's really Dr. Catacuzzi and Dr. Jessica Magidson, who is a psychologist that we collaborate with from College Park, got an R01 grant to study peer-delivered behavioral activation to improve treatment on the van. So just got funded. We got 3 years and we're starting to meet now to implement that program. And I just wanted to show you, this is our new van. We got another $325,000 from the state of Maryland because they were pleased with our work to buy the first van we bought, we didn't know what we were doing. We went to an RV. I think Rob, you were with us, weren't you? Yep, it was Rob, myself, and Joe Jones, and sort of said, okay, we'll take that one. And we kind of, we fitted it, and then we figured out we'd be better off if we could have a real medical van. So this is not out on the road yet because we're still waiting for the tele equipment. But let me just see. We went down on Friday. This is a team of like a combination of the Caroline County team, the peer recovery specialist, the counselor, our research team, and so everybody, the individuals from College Park. So it's fun. It's a great group to work with, really smart, diverse team. So anyway, that's a bit about our telemedicine program. Now we can get to the fun stuff. I was going to introduce Dr. Sarah Catacuzzi. So Sarah is an associate professor in the Department of Medicine. I think she probably would have, and she got a secondary appointment with us. I think she had to do it over again. She'd be a psychiatrist, right, Sarah? But anyway, Sarah came up to me about 6 or 7 years ago and wanted to start treating patients for hepatitis C in our opioid treatment program. And she came in, she did a great job. She treated over 100 people, cured over 100 people with hepatitis C in our 1001 clinic. And we were so busy, it was to the point where we were treating more patients for hepatitis C than anywhere else on campus. I think we see a lot of things in the same way. She's very interested in our patient populations, very bright, smart, not only a good clinician, but a good researcher. She's working with me to take the lead on setting up our new addiction center that the dean is spearheading. She's the PI, site PI on this R01 grant. And she's going to talk a little bit about a common interest we have, the interface of really severe infection and people that use drugs and some of the conundrums that they present. Thanks, Sarah.
Thank you so much for that kind and slightly embarrassing introduction, Eric. It is true that I went to medical school to become a psychiatrist, and if I could do it all again, I would have joined you all originally, got sidetracked, but I made my way back to you. And I just want to thank you all thank Eric especially for the warm acceptance in DART and all the amazing people I've gotten to meet over the last 6 years of collaboration. So I'm going to talk about what I hope is just the foundation for a new era of collaboration between infectious disease and psychiatry. And that's what I'm going to present today is some initial findings of a retrospective evaluation that we did in collaboration with some other universities, and then show you a little bit about where we plan to take this study. So just by way of background, I think it's no surprise to any of you working with our patient population that there's been, alongside the rapid expansion of heroin and opioid use, there has been a related increase in injection-related serious bacterial and fungal infections. And so you can see here, this is data out of Oregon between 2008 and 2018, but you can see this enormous rise that, of course, we know from the graphics that Eric just showed us parallel the use of opioids across the United States. So we not only have this rise in overdose death, but the infectious complications of opioid use disorder. And those patients who experience those complications often end up in the hospital system. And so we know that these hospitalizations are associated with high morbidity, high mortality, and high cost to the healthcare system. And we also know from previous data that hospitalization is an underutilized opportunity to intervene on opioid use disorder. Obviously individuals like Joy and Chris have been doing this for a long time, but I can tell you from working with hospitals around the country, even today, that's not always the case. That capacity is not always available. Despite the fact, as I like to put it, that when infectious disease physicians are obsessed with source control, and the source of most of these infections is the addiction. What we know from other work done primarily coming out of Boston is that an inpatient initiation of medication for opioid use disorder is associated with a number of really good outcomes, including higher rates of outpatient linkage to care, increased mortality at 1 year, both related to overdose and non-overdose related mortality. However, what we don't know is looking long-term, how long are people, if they have an intervention in the hospital, is that able to successfully help them reach their treatment goals? Will it allow them at 1 year, 3 years, 5 years be retained in care? And what do we need to make an impact in this population that is frankly not always treatment seeking? They're coming to the hospital to treat their infectious complication, not necessarily their opioid use disorder. So we were lucky enough in 2020 to receive funding from the NIH to conduct the CHOICE study, which the part one of which I'm going to show today some data is just a retrospective evaluation. But the goal was really twofold. The first was to delineate the gaps in care around inpatient care and the transition of care from inpatient to outpatient care, which we know is quite tricky in this patient population. And then we also wanted to utilize this data alongside some qualitative work to develop and implement an intervention to help improve outcomes in this population. So these are the 4 medical systems that were involved in this collaboration. And again, this was a retrospective review of inpatient interventions. And we really focused on the calendar year 2018, because we all know what happened soon after that, that really threw a monkey wrench in this analysis. So this initial analysis was just in the calendar year 2018, and it included patients who were hospitalized with an infectious complication of injection opioid use. So very narrow definition. You had to have both opioid use disorder as well as this infectious complication and have been hospitalized in 2018. And in parallel to this, we did at each of these sites semi-structured interviews, ended up being 24 expert stakeholders, some of whom are in the room today, to really get in between this granular data, what was really happening in the care of this patient population. So just some of the initial data, we ended up with a really narrow cohort of about 322 individuals. And overall, the demographics reflect what we know about the opioid use disorder crisis in America right now, overwhelmingly young white men who were primarily, about a third of whom were unstably housed. And thanks to our partnership in non-Medicaid expansion states such as Alabama and Georgia, about a third of this cohort was completely uninsured. And the large majority who were insured were under the Medicaid system. So just looking at the medication for opioid use disorder continuum, so prior to hospitalization, on admission, only about a third were on medication for opioid use disorder. And when we look at the breakdown of those who started out that way, the majority continued during their hospitalization on medication for opioid use disorder. However, of those not on medication on admission, less than a third were initiated. And we know that there are many valid reasons why someone might not be initiated on medication for opioid use disorder during a hospitalization, such as pain, a major surgery, etc. But what we found in our analysis was that concrete medical reasons were not the majority of reasons why people were not initiated. Many times it was just not addressed or patients left early. And that's another major finding of this analysis, was that 1 out of every 5 of these patients left against medical advice. I know that's not a surprise to people like Joy who do this work every day, but just step back and think about that. These are patients with serious infections that landed them in the hospital. Those patients are leaving an average of 2 days after admission, some of whom have endocarditis. So you can understand why there's such a high morbidity and mortality associated with this patient population. And when we looked at factors that were associated with premature discharge, we found that not having medication for opioid use disorder, not receiving any, not being initiated on it, and not receiving an addiction consult were associated with a premature discharge. We also, as I mentioned, were able to show that nearly 80% of those who left early had no plan for what was going to happen to their antibiotics. And we also found that half of this patient population within a 1-year time frame had an ED visit and a readmission. And some patients were readmitted up to 18 times within the same hospital system in the same year. And those of you who work in the hospital know those patients very well. Alongside this, as I mentioned, there was a qualitative study which looked at expert stakeholders, and I'm just going to share with you a couple of the major themes that were found from this qualitative work with some quotes, and these are actually all from the Baltimore site. So obviously stigma was a huge issue in connecting our patients to care. Lack of communication, not just between patients and providers, but between providers of different teams. A lack of standardization on the part of the medicine teams. What is the right care? What am I supposed to do? I have my great hypertension guidelines, but what do I do for medication for opioid use disorder? And then resources, just a lack of resources amongst the hospitals. And a really unclear relationship of this care to harm reduction, a stigmatizing environment, and also, an unclear prioritization of opioid use disorder, and a lack of real structure of advocacy within the hospital systems. And those are just some of the quotes that support some of these themes. So in terms of next steps, where we're taking this data, we're now in year 1, and we've been funded for this next year of this project, that we want to take the variables that we looked at beyond the calendar year 2018, expand our variables of interest, for example, looking more at methamphetamine use disorder and some more granular data. And the goal is for this year to meet with many of you in this room and others from other departments to develop an interventional study. And in the next 2 to 5 years, conduct a 3-year hybrid effectiveness implementation study across the sites that you saw, who were our original partners. And the idea is that we really want to understand what's the package of interventions that can reduce infectious disease associated infections while also linking people appropriately to opioid use disorder care definitively. Here are some of our potential interventions. This is a mix of effectiveness and implementation. So we're going to build the bridge and then study how we're building the bridge. We're going to implement it. But these are some of the interventions, which we're very lucky here at University of Maryland to have a really strong foundation in all of these things, thanks to DART. So here are some of the outcome measures that we're going to be looking at. We want to look at inpatient admission, some of the findings that we found in our original study. We want to look at long-term follow-up, and of course, understanding how are universities going to prioritize their implementation, how feasible is it, and what's the cost effectiveness of this. So just to wrap this up, infectious complications of opioid use disorder are rising alongside opioid use, and hospitalization is a really critical time to engage these patients and intervene on the source of their infectious disease. And in our analysis of these patients, there were really low rates of medication for opioid use disorder initiation, high rates of premature discharge and readmission, and that we are really excited to carry this implementation trial forward in the next 2 to 3 years. So with that, the aforementioned purple van, I need to go back to it and see patients that are waiting for me. So I apologize that I can't stay till the end of this presentation, but I'm happy. I'm the only Catacuzi in our directory. Please reach out to me with any questions. Thank you so much.
Thanks, Sarah. Our next presentation, presenters are going to be Aaron Greenblatt and Adithi Ringwala. Aaron is family medicine trained, did his addiction fellowship with us, and been on faculty 4 or 5 years now. 7. Time goes by fast when you're having fun, right? So Aaron's a brilliant individual, great clinician and educator, always kind of pushing me to think outside the box. So he and Adithi, internal medicine trained. She's initially from Wisconsin, was out in private practice working at the VA not private practice, but working for the VA doing clinical medicine, primary care, and then went and did her fellowship in New York. And she's been a great addition. She's been with us for a couple years now, just a hardworking, loves to see patients. Great educator, and they're going to talk about a program that we have at 1001 West Pratt Street, which is an attempt to integrate treatment for individuals with opioid disorder. And when I say integrate medical and mental health treatment. So I'm going to let them take over here.
Thanks, Eric. And I understand that Mimi changed the slides around. They were a soothing beige previously, but hopefully I forgive her because she came up with shot through the dark. So, so this is, as Eric initially mentioned, all of these initiatives are our team efforts, and these are just some of the additional people that have participated in the development of the program and of the evaluation as well. I just wanted to clarify a little bit about what we're talking about, because sometimes people forget that there's the other side of things that are happening on the other side of Martin Luther King. And sometimes people just refer to everything that happens at 1001 West Pratt as ADAP, which I think can sometimes create some confusion. So I just wanted to take this opportunity to describe a little bit about the setting here. So the University of Maryland Medical Center, I'm calling them the UMMC Department of Psychiatry Legacy Addiction Treatment Programs, have been at 1001 West Pratt since 2011, I believe, a little before my arrival. And they included the opioid treatment program, oftentimes referred to as the methadone program, sometimes called the Drug Treatment Center, or DTC. That is a federally licensed methadone dispensing, buprenorphine dispensing program. The ADAP is actually our office-based addiction treatment program that includes medications for opioid use disorder, medications for other substance use disorders, and counseling, as well as our kind of quiescent IOP program. There's also the Deaf Addiction Services at Maryland, which is a small program that's dedicated to the health of deaf and hard of hearing individuals in Maryland who are living with substance use disorders. And then the OTP Health Home, which is a nurse-led care coordination program that is able to administer services to individuals who are who have Medicaid, who are enrolled in our OTP. What Dr. Ringwala and I are going to be talking about today specifically is the health and recovery practice, which is an additional practice that we've been working on for the past 5 years or so. Just talking specifically about this program, the Health and Recovery Practice, that was really initiated and has been really wonderfully supported by Dr. Rackbeisel and Dr. Weintraub, building it out alongside the legacy programs. I wish there was actually a catchy name for the ensemble of the programs on site. Still operates more as a salad bar than a soup tureen, I would say. So we have everything on site together, but it's not administratively all mixed up. It's a good salad bar though. We go on to the next slide here. So this is the overview. Thanks, Google. This is West Pratt Street coming down. West Pratt Street coming down here, the 22-sided polygon of the B&O Railroad Museum, and then 1001 West Pratt, where this is all happening. Large free parking lot for those of you who would like to come and visit. So as a background, people who use drugs have many chronic conditions, as Dr. Catacuzzi highlighted. They're marginalized from mainstream healthcare. Acute care without follow-up drives cost and care fragmentation. And though medication for opioid use disorder is highly effective, patients tend to access it in locations that are disconnected from traditional locations of medical care. Our patients are MVPs. That's the catchy hospital terminology for multi-visit patients. Sounds so much better than frequent flyers, but in one data set that we looked at when we were getting HARP started, of the 516 OTP patients at the time, like 371 had a recent ED visit or hospitalization, numbering in the close to 1,500 ED visits in the period under examination, and like just multiple ED encounters, multiple inpatient admissions. On the outpatient side, there's plenty of evidence that co-locating and integrating care, be it psychiatric and medical and addiction treatment, psychiatric and addiction treatment, has positive effects on outcomes. So HIV and opioid use disorder care integration kind of drove up HARP adherence to HIV medications, decreased viral loads. A study done out in San Francisco showed that providing HIV care in an OTP actually positively affected those outcomes as well, compared to providing HIV care in the clinic that's literally located next door to the OTP. So just those few feet are enough to improve outcomes. Providing Hep C care in an OTP resulted in SVR or hepatitis C cure of around 90%, which is comparable to people receiving who don't use drugs receiving hepatitis C care in traditional settings. And psychiatric integration in primary care decreases depressive symptoms when delivered in a multidisciplinary team. So integration seems to really help with patients. And we also just hear this from our patients themselves. I saw a guy coming into our, waiting for the elevator at 1001 West Pratt not too long ago, and he said to me, "Doc, is this normal?" And he pulled up his pant leg and showed me an orthopedic nail just sticking out of his ankle. And I was able to say, "I don't think that's normal, but we can get you, let's get you seen upstairs and we can get you connected to the right care." And he was actually able to go to the outpatient shock trauma clinic that day and not end up, waiting for 8 hours in the emergency department. I think he ended up being admitted, but he did have a nail sticking out of his ankle. When we see patients for initial evaluations, we don't have to pretend that we're not seeing the bulky, dirty dressings around their legs. We can actually ask, "Hey, do you mind telling me what's going on with your legs?" And they actually are in a setting where we can be welcoming and say, when they are able to, if they're able to overcome the stigma and the shame of having a wound on their legs, we're able to say, "Well, good news is that we have people here that can help." Similarly, like when people are coming into treatment, it feels so good to me, and I think to the patients as well, to be able to offer a cure of a chronic medical condition at the time that we're taking them in for care of their opioid use disorder. We also have the ability to coordinate medications in a variety of ways. And I just yesterday, a patient with a new diagnosis of HIV was so grateful. He had been prescribed some HIV medication from an outpatient provider, but hadn't been over to the pharmacy to pick it up yet. He was so grateful when I told him, "Actually, we can get that delivered here. and we can give it to at the dosing window. What he's experiencing homelessness, he was just so glad that we could provide that for him because it was going to be able to keep track of it better. So how to do it? It was kind of hard, and it continues to be a challenge. I would say that kind of instrumental in this was support from the psychiatry department and leadership of the Institute of Human Virology. I won't go through all of these, the 5 S's that Partners in Health has used to describe healthcare improvement processes, but just to mention that we've had to make kind of cross-institutional investments in staff, in social support, in stuff, the supplies for our clinic and the space. We got private foundation support for renovations and initial staffing. We got surplus hospital and school of medicine supplies, a very nice exam table from Dr. Johnson. We had the ability to use UMMC space and the hospital EHR, and we've gotten billing support from our providers' respective departments. There's a lot of moving parts. It's a kind of a unfortunately complicated structure to put together the implementation of what's a very simple idea, which is just being able to take care of patients in one place. Just one word about the system before I invite Dr. Ringwala up here. So as I mentioned, it's challenging to figure out how to put these things together because our system is really based, is already set up to be fragmented. As Dr. Israel pointed out, just as people who experience trauma tend to dissociate, systems that are based in trauma tend to be dissociated as well. I like that metaphor. So as an example of some of the barriers that we encountered, UMMC, won't or can't bill for medical or psychiatric provider visits. There was pretty scanty hospital support for and financial logistical support for expansion of services to this really important population. The solution that we kind of came upon was to build an entirely separate faculty practice-based multi-specialty practice right alongside the legacy addiction programs. And so that's why we have these multiple institutions in one clinical space. And as Dr. Ringwala will describe, this actually put us on a path to, as Dr. Weintraub, Dr. Amoroso and colleagues were able to identify, put us on a path to being able to access some additional funding to support what feels like a very important clinical initiative. So I'm going to invite Dr. Ringwala up to take the baton. Thanks, Aditi.
Right. Hi, everyone. So speaking of the additional funding, there was upper payment level funding that is defined as an average commercial rate above what is received through Medicare. And that's something that HARP was able to receive. The way that they were able to receive it was by proving to the state and federal partnerships that we had a demonstration project. And so I'll go over the demonstration project at the end because we do have some preliminary results from that project. So the goals of HARP, especially for the upper payment level, include medically engaging the population that's most at risk, reducing ED utilization, and decreasing inpatient hospital stays, and addressing social determinants of health. So how we do this is by offering HARP services on site. Our services include primary care, infectious disease, psychiatry, psychology, urgent care walk-ins, wound care, and harm reduction practices like syringe exchange services. This is kind of the makeup of the OTP. We have about 60% of our patients are male, 60% African American. So that's kind of the biggest patient population. So what we've done in the last year from September 2021 to September 2022, we've seen about 325 patients that consider us their primary care doctors, which is about 57% of the patients that come to the OTP. A lot of what we do is walk-in visits. So patients come in, need urgent issues addressed right then and there, and that's 33%, so a third of what we do. We also see patients uniquely for non-primary care visits, and that's 223 patients. So the total visits we've had in that year is 3,483. So in reference to what I had previously mentioned, what we're looking at is avoidable ED visits. The goal, the baseline for 2017, 18, and 19 was 1,000 or 109,000 patients, and the goal was to reduce that by 5%. And fortunately, so far, it looks like we are on track. As of January through July, we got that down to 63,000. In terms of preventing admissions, the goal was to reduce that by 5%. And we're at 4,703 between January and July, and that is annualized. And then the patients that we do see, we try to screen them for social determinants of health so we can help intervene. And we're able to so far screen 38.5% of our patients. So we're on track to meet our goals. In conclusion, integrating and co-locating care is hard to implement, but it seems to be working. The psychiatry department and DART have been very supportive in our goals, and we'd love it if you guys could think of us for your patients that have both medical and psychiatric needs and need addiction treatment. Thank you.
Thank you. We're running way behind as I expected. So next person is gonna, Mimi, I think you're next, right? So we're fortunate to have Dr. Mimi Belcher working within our division. She's been with us for the last 3-4 years. Yeah. Anyway, she's been a great addition in a variety of ways, even though so she got her PhD in neurobiology and behavior from UC Irvine, did a postdoc at NIDA and joined the faculty in 2014. She, even though she's more of a basic science researcher initially, she's really taken to clinical work and become our translational expert, and really it's just been an asset in all areas of the department, not only on the research side, but in education and mentoring our trainees and faculty to help them write papers. Fortunately, Mimi, I'm like, you're only going to have about 10 minutes to do your thing. So she's going to talk about our jail program. She and I wrote a grant together, and she's going to describe how it's going. Okay.
I have to figure out where the button is for the 2.5 times speed. So thank you for that super, super embarrassing, wonderful. So I taught Eric how to do this, then I can't do it. So I'm going to talk a little bit about our jails program, our telemedicine evaluation for people who are incarcerated in rural areas of Maryland, just some basic background. And this is nothing really very terribly novel or new to any of you. 58 to 63% of people who are incarcerated meet criteria for substance use disorder. 15% meet criteria for opioid use disorder specifically. And we know that the period following the release from jail and from prison is an extremely vulnerable period of time for people who are at a very high risk of suffering from an overdose upon release. And I love this because I think that this paper, which is a really important one demonstrating this, is also, it's got this wonderful graphic, I think it's figure number 4, Binswanger et al., who did a retrospective cohort study of people who were being released from prison. And you just see this very pronounced, I don't know if you can see my cursor, but this very pronounced first 1 to 2 weeks overdose rate, which is just, significantly higher than for all the other periods following. People come out of jails and they overdose at much higher rates. So this is a very important period for an intervention, for treatment. As Dr. Weintraub and Welsh and our other physicians who do some of the telemedicine work were sort of encountering patients in these rural areas, I think they were all struck. I've had conversations with Dr. Weintraub about how struck they were about the revolving door. So seeing patients coming in and out of treatment, back into jail, withdrawing, and then immediately, having to hit the ground again with an overdose, and then, coming back out. It's just this nonstop cyclical nature that is actually characteristic of opioid use disorder, but it's particularly pronounced and acute in this sort of population. And so jails seem like a very great place to have an intervention with telemedicine, to be able to reach people prior to release and before they go into the community and encounter that risky, vulnerable period. So as Dr. Weintraub mentioned, we wrote a grant and we were lucky to secure 600,000 in funding over the course of 2.5 years. We're in a no-cost extension phase right now, but basically the Foundation for Opioid Response Efforts funded us to start a clinical service that would be penetrating the jails, so getting into the jail system in rural areas and delivering buprenorphine treatment, starting people before they were released. So far, we've implemented in 3 different sites. The first was in Talbot in August of 2020. The second site was in Allegheny on the western side of Maryland. And then the third site also in the Eastern Shores in Kent. And there's one that's going to be starting up soon that I think Dr. Spicen is going to be sort of spearheading in Somerset. We put together a retrospective analysis of the people who were in the Talbot Detention Center and wrote, this is the first publication to come out of this data, and Frontiers in Psychiatry, and just really laid down the groundwork for the programs in general. And I just love this picture. I had to insert this somewhere. We have in our third site of implementation it's the second site, I'm sorry, has really been the sort of the star, the most impressive of all of the 3 sites. And, you know, there's a very willing environment. The warden is incredibly open-minded and really has worked hard to make sure that this program works. And so there was a visit by Congressman Trone, who just won in his district, which is exciting. So we started program evaluation from this jail in particular. This is Allegheny County Detention Center so far. So what we do is we look at patients upon discharge. And so we've seen 116 patients, over probably closer to 300 or more individual encounters have been done by our docs. What I'm showing you is the data upon release, because that's when we have access to the data. But generally, the demographics are a mean age of about 34 years, predominantly male, white, non-Hispanic, and single, most of whom endorse at least one comorbid mental health disorder, largely depression and anxiety. In terms of the predominant reason for incarceration, possession, 60% report IV drug use as a most recent and as their choice of opioid administration. And they have about an average of 13 years history of opioid use. And the mean length of stay in the jails for this cohort in particular is about 100.
I couldn't, he wouldn't let me through. He wouldn't let me out.
I'm not sure how. I'm so excited about the enthusiasm, but I'm excited about this program as well. In terms of the mean number of days in our care, our docs are seeing patients for approximately 2 months within that time that they're incarcerated. So the question that we've been really sort of bedraggled with for a long time is what happens after release. So we've been doing a lot of really nice characterization within the jail and within the setting, but we're just really excited to begin. We have IRB approval to begin looking at outcomes upon release, because that's really, that's kind of where the rubber hits the road, right? So you want to understand what sort of an impact is this program having once they're back in the community. And so we've started doing this at Wells, at Allegheny. And so I'm showing here for 103, again, these are discharged patients who have been released from the program and are now are in the community. For several reasons, I've decided to filter several of these people because they wouldn't really be adequate to look at as a person who would be picking up a buprenorphine prescription in the community. So that's our primary outcome. How many people are picking up within 5 days and within 2 weeks a prescription in the community is sort of endemic of their treatment in the community. So those are our outcome measures. So of these 103 people, several people were transferred to other correctional facilities, transferred to an inpatient or halfway home type of a treatment, Sublocade injection, which is a totally different formula and would, not be picked up within 5 days objectively. So, and then 2 people were lost to follow up, but we were able to follow out 72 people who were released from the jail and who had an appointment to continue their treatment in the community upon release. Of those individuals, 58 or 81% filled a prescription within 2 weeks of release from the jail. And so, I mean, this is an enormous number, and I think it's very exciting to me, but I think when you put that against the backdrop of the fact that these people would probably be released with absolutely no bridge to treatment at all. I mean, the likelihood that people leaving the jail would be continuing or finding treatment upon release is almost, I can almost guess it would be 0. So just to put that into perspective a little bit. If we follow the patients who specifically were provided a bridge prescription by one of our docs, so either Dr. Weintraub or Welsh providing a prescription prior to their release, we had a total of 51 patients who were provided buprenorphine prescriptions. 88% of these folks, 88% did go up and pick up their prescription within 5 days of release from the jail. And from that 88%, that should have said 82%, I'm sorry, 88%, 37 of whom continued to pick up prescriptions within 14 days of release. And so this is, again, sort of our way of being able to say something meaningful about their continuity of care for the first 2 weeks following release. And then anecdotally, several of these individuals have continued their treatment in the community, and a few have transitioned to Spoke community telemedicine treatment with our docs. I know that Dr. Welsh has at least 1 or 2 who are in Wells House. You're continuing to see them. Couple in Oates, that's right. Yeah. I'm going to transition for 2 more minutes and tell you about sort of a spinoff of this program of research. So this is a clinical service evaluation project, but we've become increasingly more interested in stigma and acceptability because, as we were sort of going to different spaces and trying to implement the grant in 3 different sites, which is what we were funded to do originally, there were varying levels of sort of willingness to adopt the program, right, if you will. Kelly, we can all talk about, at length how varying levels of people wanting or not wanting the program, a lot of stigma. So acceptability is an important factor in the assurance of program validation. And so we ran a small pilot in the Allegheny jail just to understand acceptability of our treatment program, also to understand perception of how people perceive the efficacy of these evidence-based medications for opioid use disorder. Do they even believe that they're useful or effective? And then thirdly, we wanted to understand if there were any stigmatizing notions surrounding medications for opioid use disorder. And so this small pilot was run in 1 jail with a variety of staff, and just very quickly, high numbers mean high acceptability, low numbers mean low acceptability, and across the different levels of staff, correctional officers really were the ones who kind of hated the program the most. The mean overall score on this measure was somewhere around 2.5 to 3, which isn't really poor, but it was being completely dragged down by these 20 correctional officers who were really just unhappy with the program. And so when you dug a little bit more, and this was significant at a group level, digging a little bit more, these are also the same individuals. They tend to be the same individuals who dragged down the score on their perceptions of MOUD efficacy. So do we think that, buprenorphine is actually a viable medicine? Should people be given methadone? The answers are no. And so this sort of gives a fair amount of understanding of why they think that the program is not very good. This one is completely inverse. And so this is completely disagree. Higher numbers mean completely agree. So I'm just orienting you because this can be confusing to look at. And again, a significant group difference across the board on the mean level of their ratings of stigma and the assessment of stigma. So again, the correctional officers were highly stigmatizing notions towards MOUD in general. So we gathered this data up and sort of brushed ourselves off and felt pretty good about what we were doing, and decided maybe this is something that we could pull into in terms of more grant funding and sort of as an academic project. And so we've gotten 2 small internal awards. We have a group. We've reached out to some folks at Penn State Altoona, Nathan Cruz and his team, who are really wonderful collaborators, and they understand very deeply how to assess stigma in all of its levels and different forms of stigma. There are different types of stigma. And this is our logo, Accept MOUD. So the idea is over the course of a 1.5 years, we're going to be approaching more than just the 1 jail, gathering data from as many as 5 different sites, and getting all of these measures, and then a lot more to understand, not just quantitatively, but also qualitatively, people's all of the above, the perceptions, the stigmatizing notions. So very excited about that. And I hope, to be able to share some results pretty soon. Program funding is on the left, is all the clinical services. So this was funded originally by the Foundation for Opioid Response Efforts with state funding and from Baltimore. And then the Academic projects, the stigma projects are really funded by IRIS and the CARES group here at the University of Maryland, Baltimore. Thank you.
Thanks, Mimi, and thanks for being so quick. So Kelly Coble will be our next presenter. Kelly's a social worker who I initially worked in the child division and has been working half-time with us on our addiction division for the past several years, and has many strengths, and including operationalizing and implementing programs. And she's going to talk about our access programs. Thanks, Kelly.
I was curious, Eric, how you would introduce me. I think we were all taking bets on our introductions, but it was good. I thought it was wise to avoid the years. Thank you. I will be mindful. We had a shared agreement of 8 to 10 slides, and I think some of us were more successful than others, but now we're down to the wire. So Chris and I have to really stay tight. So I'm going to pivot a bit. You've heard a lot about the direct services that are offered within the division. I'm going to talk about our access programs, which I'm really excited to do. It's something I'm extremely passionate about. And accidentally, you've met a lot of our consultants, and some others are in the room. So you've already met our A team. So we actually have a really rich history here in the department and in the state of Maryland of running really strong and wide-reaching access programs. So MAX launched in 2017, and I will focus primarily on MAX, the Maryland Addiction Consultation Service, but I'll talk about our other offerings and tease maybe some other states that are actually interested in us helping them launch access programs. But I'll just give you a bit of background, and I'll be brief and be sure Dr. Welsh gets up here as well. But in 2012, Maryland launched BHIP, which is the Behavioral Health Integration in Pediatric Primary Care Service. And because of the success of that program, the state approached our department and asked if we could think outside the box. And Dr. Weintraub already alluded that we tend to be a group that says, sure, we'll figure something out. We're happy to come up with an innovative approach. And this is where MAX was born. But to just give a bit of background, I think this is a room of folks that are well aware of the fact that there are not enough behavioral health professionals to respond to the behavioral health needs of individuals in our community, across our state, nationally. So in 2017, BHA came to our department and said, we have an opioid crisis. BHIP has been really successful in responding to the needs of children and adolescents. Could we think about replicating that? And Maryland actually is the first state to have a behavioral health, or I'm sorry, an opioid consultation service, which is MAX. And we've really evolved. So I'll talk us through that a little bit. But this is the group of access programs that we have now. You can see that they're really robustly funded, and they've gone well beyond just opioid use disorder. So we now have access programs that respond to all substance use disorders. We support perinatal providers, and we also support providers in the District of Columbia. So our neighbors to the south, I guess. Dr. Weintraub talked a little bit about this, just about the lack of access in general. There aren't enough waivered providers available to care for patients. So this is a step back, not quite as intense, right, or in office as what Dr. Greenblatt and Dr. Ringwala talked about, but a way to provide sort of co-located or collaborative care that can look a lot of different ways, right? It can be in office, it can be peer-to-peer consultation. You could have an arrangement with someone next door or down the street. But what we do in MAX is we provide those services via phone. Oops. So we have an array of services. They're all free. They're anonymous to the patient. So it operates very much like a curbside consultation. So just like you would do in the hospital with a peer or a colleague, you can pick up the phone Monday through Friday, 9 to 5, and you can call one of our consultants. So like I said, you met a bunch of them today. We have a really large, actually deep bench at this point. So we can take questions about infectious disease. We can take questions about pain or the intersection of substance use disorders and pain. We get those questions a lot. Excuse me. We can take questions about pregnant patients. And our phone line is staffed by a social worker who has experience working in a treatment center, so she can answer general questions. For example, last week, we had a call about a patient that was 36 weeks pregnant and had been discharged by her provider, and she had a serious dental need. She had an abscess, so she needed a dentist, she needed a primary care provider, and a treatment center. So that call doesn't need to go to Dr. Welsh, who is one of our consultants for perinatal patients, but Tracy can handle that, manage it on the front end, and we make sure that we get patients connected with resources. We provide a lot of education and training opportunities. So some folks in this room may have participated or been a part of that. Dr. Catacuzzi and Dr. Welsh do a lot of training for residents and fellows. We offer a lot of waiver trainings. One of our focuses is to ensure that folks in the state get their waiver and then use it to capacity. So at this point, we've waiver trained over 600 folks in Maryland since 2019, excuse me. And then we also do a lot of technical assistance. So something we realized was we were getting questions beyond, how do I help this patient? But we were receiving questions like, you know, J-code just visited and they gave us feedback and we don't know what to do with it. Or we opened a practice, but our neighbors down the street, they don't want those people hanging out outside. We need a loitering policy. So we went back to the state and we said, you know, this is a little bit beyond our scope. And that's when we received additional funding. And now our consultants, Dr. Greenblatt, does a lot of this, works with practices to really think about how to ensure they have policies and procedures that really are, you know, fully encompass what a practice that's providing MOUD would want and is reflective of best practice. And then we provide echo clinics. So right now we're running 3 distinct echo clinics. We have the first nationally that's specific to OTPs. We just conducted qualitative interviews to get feedback around that. Dr. Belcher helped, and we've started to write that up, and we look forward to disseminating that. This looks at our enrollments around the state. So it's not a requirement that we do ask folks to sign up with us just to, you know, facilitate easy communication with our providers and provide information back to them about their calls. So we have folks engaged and using our service across the state. It's reflective, of course, of the population in each county. There aren't going to be as many prescribers in Garrett County or Caroline County as there are here in the city, and you see that reflected in the numbers. The majority of folks using our service are prescribers, MDs, DOs, NPs, but we don't turn anybody away. So if a behavioral health provider or someone from a health department wants to call, we of course help them. And they might have a question about who in their community they can refer to or something like that. We take those calls. The bulk of our calls are clinical, so maybe about dosing or patient management, but we also get questions, as I mentioned, about resources and referrals, about how the service works, how to connect with us, and as I mentioned, technical assistance. The bulk of our calls are about opioids. That's how our service started. And then we expanded to take calls about other questions. So you see that reflected. We, as I mentioned, have been around about 5 years. We're starting to disseminate information about our work and have some forthcoming information, thanks to the support of Dr. Belcher and others. Happy to take questions at the end and are looking forward to expanding, hopefully, to Delaware. And we have a call after Thanksgiving with Wyoming, Montana, Idaho, and Nevada. So there's more to come. But we, you know, just to highlight this, Maryland is the only state nationally that has this whole array, perinatal, child, and addiction. So we should be proud of that and encourage providers to use it because it is a way to increase access. I think, Dr. Welsh, I will turn this to you.
Thanks, Kelly, keeping us on schedule. So last but not least, Dr. Chris Welsh, an associate professor in psychiatry. He's been a friend and a colleague of mine for I don't know how many years, but we work together really closely in a lot of the programs we've talked about, he's been on the ground helping to operationalize and implement them. Incredibly hardworking, well-read. He's another faculty member that's always pushing the envelope to make sure that we're doing the best we can to take care of patients that have substance use disorders. He's well-known in the medical school for carrying his little box of different trinkets that people use to use drugs. But anyway, he's going to talk a little bit about it, some international work that he's done to top things off. Okay, thanks.
Thanks. Yeah, since COVID, no one's seen my drug briefcase, so one of these guys probably know what it is, but. Okay, so real quickly, I'll go through, I don't know how many people are even aware, but we've, I mostly now, but we started, I'll talk about Eric, and doing this in Kenya. And it's all funded through CDC PEPFAR money. So younger people may not be aware, in 2003, Bush started this program. I think it's spent over 100 billion in HIV treatment, prevention and treatment in Africa and other areas. So that's who funds this. Just a little bit of background of why Kenya, just if people aren't familiar with where it is, here in East Africa. And this is really significant because, for decades up and through the 80s, most heroin came from people called the Golden Triangle. So Thailand, Laos, Myanmar, Burma here. And then we started to see in the 80s into the 90s a big change internationally. And almost all of the US started coming from Mexico, kind of to the west, Colombia to the east, and then kind of shifting to Afghanistan, Pakistan, Iran, people call the Golden Crescent, for Europe, Asia, and less in Africa. And what started happening was it was being kind of going up this way, but then people started shipping it down across the Indian Ocean to the coast of mostly Kenya and Tanzania. And so that's when we started to see in the late 90s into the 2000s that Kenya started developing a big heroin problem, a lot because it became the stop off point as it was smuggled up into Europe. Just a little, I won't spend time on this, but this really is kind of the World Health Organization foundation of how to treat and manage people with HIV who inject or use drugs. And a big part is using opioid medications. So what happened it was the end of 2013, I got a call from Anthony Amoroso, who's been real involved with HARP and other things from our IHV. And he was really the key person with a lot of the African PEPFAR, funded initiatives then. And Kenya was really struggling with the, what was going on with heroin use and how it was affecting HIV. And they had said, we would like to see if we can use some of this funding to start methadone clinics. And I don't know if people remember, but this was about 2 months after the big, if people remember, I think it was September 2013 was the big mall massacre in Nairobi, where there was a Somalian terrorist group that took over. I think 70, 80 people were killed. So I wasn't really sure that I wanted to commit to going over to Kenya to do this. And at the time there were Americans couldn't even travel there, whatever. But thought, this would be probably good. So, approached Eric and started planning this. And we won't go through all this, but just a lot of the things of how to think, how are you going to start doing medications like methadone in a country that doesn't have it? They had actually started looking into it because Tanzania, which is right to the south of Kenya, had started a methadone clinic the year before. So people from Kenya had already gone and visited them. They had actually already written some standard operating procedures, largely based on the United Nations, UNODC, the United Nations Office of Drugs and Crime, their kind of input on how to do this. But we started in early 2014, meeting here, and then we would do Skype visits with people in Kenya to try and, again, help kind of put in place a lot of these things that they would need there. And we had, so it was me, Eric, Denisha, who was the head nurse at the methadone clinic then, and then Jewel, who's the clinical director and kind of the head of psychosocial and counseling. So it helped them kind of figure out, which methadone dispensing software, hardware. Tanzania, they were actually buying powdered methadone and mixing it themselves, which we didn't think was a really good idea. So we helped find like where could they get, premixed, et cetera. Just to show you, they had already decided it was going to be at this, this is actually a national psychiatric hospital there. It probably wouldn't be unlike Spring Grove or just some pictures of the hospital. And they had already decided they wanted to put the first clinic there. So we plan to go in September and have the first, the clinic open, patients start. We get there and, wasn't kind of ready to go yet. If you see here, we were going to be there for 2 weeks and they assured us that by the end of the 2 weeks, it was going to be ready. But it was really interesting. So we're trying to do trainings. They're doing construction at the same time. They're, they needed security and other things like to store the methadone. This group, their equivalent of the DEA, they didn't have enough, obviously, safeguards there. So yeah, we were meeting with them and then meeting with other key stakeholders. The way it works there is they have these drop-in centers that are run by non-government organizations that do a lot of, like they give out needles, they have meals, they have groups in these things, and everyone that gets in the methadone clinic comes through one of these DICs. So this was our big meeting with the initial DIC that was going to provide the first patients. One of these guys stole my wallet and phone. Like the first couple of days we were there, I didn't have any credit cards or anything for the whole rest of the trip. So, but again, everyone's excited that this was going to happen. Ended up not happening. They didn't get it finished in September, but they did open in December of 2014. So went back in June and they had nice signage now, was looking a lot better. They had a big kickoff in August of 2015 with, all the national, people from the national government there. We weren't there for any of this. Then they decided they wanted to make a second clinic. So I was there in the spring of 2016 and they had identified another site. This is just another kind of area of Nairobi. And within a few months, if you see, these are like just big, metal structures that they built this entire clinic. Stacking these, and it kind of these two pictures are from up here. So it kind of wraps around. Unfortunately, if you can see here, it's right next to a place that makes tombstones, which are literally there as you enter. I don't try to get them to not put this big sign, advertising the big methadone clinic there that no one wanted there. But regardless, they opened this second clinic. Which, really took off. Mathari kept growing that initial clinic, the patients were decorating it. They ran out of space in the buildings. They started setting up these temporary, tents to hold their groups and all. So we were really involved with those initial two with the first round. And just to show you, this is the area, the coast here is where all the heroin comes in. Mombasa is one of the biggest ports on the west of Africa. Malindi actually had heroin also back in the 70s because it was for some reason, Italians started coming there. They actually called it Little Italy of Africa. And so Italian tourists brought heroin, but it was very, constrained there. But again, their real problem started as it all started being smuggled through. That's the second clinic. This town here is on Lake Victoria. I haven't been out there yet. I'm not sure what that looks like. It's much more rural, but another clinic opened a couple years ago that's run by Doctors Without Borders. Most of the other ones are related to either us or not affiliated with another group like that. So they've done a lot, and then just last year they added this one here is mobile that I'll talk a little bit about. This is the van that they started last year because there the distances are just so far for people that are not really in the city. Many people don't have cars. Their public transportation is really poor. So they wanted to at least be able to help some. So they identified a few areas. They're still technically in Nairobi, but many, many miles away from where the clinics are. And then these are some of the coastal, again, it's on the Indian Ocean, really pretty. I wasn't able to visit until a few years ago because of the terrorist activity is a lot worse on the coast. It's much more Muslim there, and that's where a lot of that's coming from. Fairly similar, the clinics there. So just a little bit showing, these are just the two clinics that we're primarily involved with in Mathari and Ngara, just showing since 2014, the number of people that they've started, and then the number that are still in treatment there. And some of the years there was a period in here where you see the retention was a lot lower. We don't have time to talk about that, but again, really doing a good job of keeping people in treatment. Part of the problem there is they don't have take homes. So literally everyone has to come every day. They have to staff it, 24/7, or not 24/7, but 365 days a year, really trying to get them to loosen that, but they still struggle with that. So to have retention when that's such an issue is a big problem. Just a little bit that, it stands out here. It's primarily male, but 10% female. Some of the others have talked about this. Again, this is all funded by HIV prevention money. So they really have to look at that. So this is just, there's a lot more with this, but how much it helps having people getting their HIV care in the OTP versus outside. So just some of the challenges, and see we're past time, but things that we hadn't even thought. Here we worry about blizzards, hurricanes, things like that. There, and this actually, when we went in September, we went to meet with the Minister of Health, and the physicians were on strike. And they very commonly there, every type, pharmacists, nurses, physicians strike fairly often. So we're like, you can't run a program where everyone has to be there every day if you can't even have the people there. So what ended up happening, some of the CDC money, which was not supposed to pay for staff, was used to pay for staff to make sure that they wouldn't be able to go on strike because they weren't employed by the government, that kind of thing. So things that we hadn't even thought before we got into that. Unreliable medication supply. They several times now have had where they ran out of methadone and it was stuck on a boat somewhere. I don't know if you can see this, but there's 1, 2, 5, and 10 milligram per milliliter, all different strengths that they've gotten, which is really a setup for a major problem if you don't adjust it. So okay, so that was it. So if you guys have, Asante means thank you. That's what it is.
Thanks, Chris. I appreciate everybody sticking around. I know we're at the end of time. I think all of us can stay if anybody has any questions. Is that okay, Jill? Or yeah.
Also email.
Yeah, or you can email questions. I don't know if anybody has any questions, comments about any specific talks. You just want to email us. Mr. White. Yeah.
Dr. Volkow is in favor of deregulating methadone. But what are your thoughts about that?
I think it's a good idea if they do it in the right way. Whatever, yeah. I think it should be less structured than it is now. We actually, Dr. Greenblatt wrote a op-ed to the Mayo Clinics, kind of talking about some of the restrictive policies. So I think it would be a great idea. Hey, I did want to jump in and say one thing. I didn't give credit for Dave Flax and his team for all the work they do. For us, a lot of our telemedicine is really dependent on what he's able to set up for us technologically. So Dave, thanks for all your help, and you've traveled the state with us, I know. Okay, so why don't you guys just send us any kind of emails? I know it's been but I want to thank everybody for presenting. Appreciate it. Sure.